The first speaker in this set of talks is going to talk on the situation of stewardship in primary care and auditing and feedback responses that can feed into those practices and programs. Kevin Schwartz is is the division head for infectious disease at St. Joseph's Health Centre in Toronto and co-medical director for antimicrobial stewardship at Unity Health Toronto. He is an academic infection control and antimicrobial stewardship physician at Public Health Ontario, an assistant professor at the Dalai Lama School of Public Health and at the University of Toronto, and an adjunct scientist at ISIS. His clinical area of interest is adult and pediatric infectious disease and tropical medicine. His research interests include vaccine preventable diseases and antimicrobial stewardship, with a particular focus on improving community antibiotic use to slow the spread of drug-resistant infections. And Kevin gave great talks last year at our symposium, and he's back this year to give us some updates. So please welcome Kevin to the stage. Nice to see you.
Thank you very much for having me. With that, I will jump right in. I don't have any conflicts or disclosures for today's talk. So the objectives for today are to describe the risks of antibiotic overuse, which I'll do fairly briefly for this audience, interpret recent data on the effectiveness of antibiotic audit and feedback in primary care, and then I'm going to discuss the implications for incorporating antibiotic audit and feedback into AMR action plans and antimicrobial stewardship in general. And so antibiotics are overused, and it's a big driver of antimicrobial resistance. There's a number of studies that have looked at this. This is one example that we did a few years ago on a cohort of family physicians in Ontario from this study, we estimate about 25% of antibiotics that are prescribed in primary care are for that group of conditions that are either never need antibiotics or would rarely need antibiotics. And so this is probably a conservative estimate of where we can move the needle in primary care antibiotic use. Antibiotic use is highly correlated with antimicrobial resistance. And again, I think for this audience, I'm not going to spend a lot of time on this, but I just sort of to highlight a couple meta-analyses where there's hundreds of trials that have, not trials, but studies that have shown this at both the individual and also population levels, that the more antibiotics you use, the more resistance that we cause. This is a nice study done a few years ago by a group in Israel that looked at community neighborhood fluoroquinolone use and its association with fluoroquinolone-resistant E. coli. And for each quintile of increased use by neighborhood, you see an increase in resistance in urine cultures with fluoroquinolone-resistant E. coli. And that's true for men and women. And then the figure B on the right are basically when they removed anybody that themselves received fluoroquinolones from the analysis. You still see a very similar pattern, that even people who had never received that antibiotic are associated with higher resistance in their urine just from living in a neighborhood that tends to use more. So it's a very sort of public health population level impact of our overuse of antibiotics. And the amount that we use, even for each additional day of antibiotics, we think is important. This is a study from a few years ago where we did an umbrella review where we looked at the randomized controlled trials that compared short versus long duration, and the vast majority of these were non-inferior trials, meaning that the outcomes were the same whether patients got shorter or longer duration, so the clinical implications were equivalent. But none of these trials are powered for side effects or resistance from antibiotics, so we pooled all of that data and are able to demonstrate that for each additional day of antibiotics patients receive, there's about a 4% increase odds of antibiotic-associated side effects. There's also a 3% increase odds of resistance, although again, there was a few studies that actually looked at this and the limited data collection, so that was not statistically significant. But we think each additional day of antibiotics is associated with significant harm. In Ontario, this data is available on the Public Health Ontario website. And so the top line is all antibiotics used in the community as number of prescriptions per 1,000 inhabitants. And just the line below that are the primary care physicians. Those are the family doctors, general practitioners. So by far the single highest group of prescribers in Ontario for community antibiotics. And it's why it's been a focus of ours. So I have an interactive component. If you'll just indulge me with your phone, you can take a picture of that QR code, or you can type in that link, slido.com, and enter that number. In the link, I just want you to answer the question if you don't mind. So what drives inappropriate antibiotic prescribing in primary care? We'll see if it works. It should work. Says somebody's typing, and then it should generate a word cloud about sort of what people think drives inappropriate antibiotic prescribing. You can answer more than once. Do not put the number in that field. You just put your answer. If you scan the QR code, you do not need the number. Unless a lot of people did that, that should get relatively small. So I'll give everyone like a minute or so to answer and have it generate. I'll just have a drink. Yeah, so a common answer, patient demand, fear, viruses, so it's probably like diagnostic uncertainty, and there's a few iterations of diagnostic uncertainty in there. Yeah, fear. Good. Yeah. Yes, thank you for participating. And so, I'll jump in just to keep going and highlight this is a really nice study. It's a systematic review of the qualitative evidence for overprescribing of antibiotics in primary care. And they group it into these, big bins. But the bottom line, it's a complicated issue with multiple reasons for overprescribing. So they lump it into external factors. These are things like organizational pressures, time constraints. There's prescriber factors, so things like, prescribers' experience, their habit, what they just usually do in that scenario, their training, anxiety or fear of something bad happening, diagnostic uncertainty plays into it. There's a bunch of patient factors as well, sort of perceived expectations, patient asking for antibiotics, or the doctor thinking the patient wants antibiotics. Socioeconomic factors, language, communication barriers, sort of medical understanding. So all of those things factor in, and they factor into varying degrees and different degrees between different patient interactions, different physicians, and different patients. This is not one thing that we're trying to change. There's actually many things across different types of settings that we actually need to be addressing to improve antibiotic use. And so one of the areas that we've been interested in, because it addresses, I think, some of the most challenging and key parts of this behavior, is audit and feedback. Audit and feedback, just sort of like as a definition, is defined as measuring an individual's professional practice and then comparing that to some standard or target, and then feeding back to the prescriber or the provider. And in general, this is an effective way to change practice. This is a Cochrane review done by Noah Ivers now over 10 years ago, and it's being updated now, but there are hundreds of trials that have looked at audit and feedback to affect professional practice. And overall, it works. This does improve professional practice with huge ranges, though, from not effective at all to very effective, depending on largely how it's done, but also in the setting that it's done. And so what we set out to do in this trial that I'm going to show you is study it in primary care doctors for prescribing antibiotics in Ontario, answering the question, does audit and feedback reduce antibiotic prescribing? We embedded some other questions within this about whether or not we can improve the way that we do audit and feedback. The sort of rationale behind the way we design this are the way that doctors often respond. We ask them about audit and feedback. They very frequently respond that, well, they didn't believe the data because their patients are different. Their practice is different. It doesn't really capture their patient complexity or unique practice. The other thing we hear from docs is that, captured in the word cloud is sort of this fear element. So they're worried that something bad is going to happen, and they feel like it's safer to prescribe antibiotics, but really, they're in reality the scenario where the antibiotic is not going to be beneficial and there are harms of antibiotics. There's this imbalance of perception of risk. And if we could try and rebalance that a bit, could we then improve their response to the audit and feedback we're giving them? So that was the rationale behind how we designed this. And so what we did was we did a randomized trial that there was randomized 4-to-1 to receive a mailed audit and feedback letter on antibiotics. Within the intervention group, we did a factorial trial, a 2x2 factorial trial, to study these different questions within the intervention group that got the letter. And we ended up enrolling about 5,000 family doctors in Ontario into this intervention. And we did it in early 2022. So I'll just show you what the letter looked like fairly briefly, but this has all been published and available. But so this was, if they got the adjusted letter, this was the first page that they got. So it's a personalized letter. It has a figure with their data and some language around, why they're receiving it and what we're asking of them. And then we tried to focus this letter on data that their data was adjusted for their patient factors, their practice factors. We highlighted that they're compared to physicians that are similar to them because the data is adjusted. And there's more detail in the appendix, but we used hierarchical regression modeling to basically do standardized antibiotic rates that are adjusted for all of these patient and practice factors. The unadjusted or sort of standard letter group looked like this, and that it was otherwise the same letter, but there's no language around the adjustment. There's no language about the physicians being similar to them that they're compared to. They're just told they're compared to all other family physicians in Ontario. The second page of the letter, this is the harms letter. So we sent them an infographic that had details about antibiotic harms, side effects, antimicrobial resistance, and language around that. And then the docs randomized to not the harms letter got this, was just the infographic on the lack of benefits of antibiotics, but none of that language or infographic on the harms. So that was basically, in a nutshell, the intervention that we did. The rest of the letter was the same that all the other doctors got who got the intervention. So it included some data on durations, and we've shown in past interventions that this is very effective for reducing prolonged durations, and we gave them their data about the proportion of their prescriptions that are more than 7 days, since most community infections can be treated for less. We also include some evidence-based communication tips and resources from Choosing Wisely Canada to try and get them to improve their antibiotic prescribing. And the letter is co-signed by Ontario's Chief Medical Officer of Health, the Ontario College of Family Physicians, and the Chair of Choosing Wisely Canada. So this is the raw data by month, and so just to highlight a few things. So antibiotic prescribing went down quite a bit during COVID, and then we did this intervention as things were normalizing a bit with more respiratory infections and more antibiotic prescribing. You can see where we did the intervention in early 2022. We start to see a separation between the blue line, which are the control group that did not receive any audit and feedback, and the yellow line, which is all the intervention arms. And in our modeled results, in the final results at 6 months, we saw a 5% reduction in overall antibiotic prescribing between the group that got an audit feedback letter and the control group. We looked at a number of other antibiotic prescribing outcomes as well. So overall unnecessary prescribing, we looked at prolonged duration prescribing and broad spectrum prescribing, and all of these decreased in the intervention group compared to the control. In our factorial trial, where we tweaked and modified the letter, we actually saw no reduction in the adjusted group, and we actually saw a small but statistically significant increase in antibiotic prescribing in the group that got the adjusted data compared to the standard letter. It was only 1%, but it was significant. And then the harms analysis, we found no significant difference in either direction for that, including that harms infographic and messaging. We repeated this at 12 months and got very similar results. So the bottom line from this randomized trial, including almost 5,100 family doctors, is that antibiotic audit and feedback as a mailed letter significantly reduced overall prescribing, necessary prescribing, prolonged durations, and broad spectrum prescribing. And that overall prescribing is about 5%. I was just going to, again, show pretty briefly, but we're also in the process of doing a cost effectiveness analysis, which is not published yet. But just to highlight, this is a very cost effective intervention. It costs about $5 to do this mailed audit and feedback intervention per physician. We estimate we save over $20 per physician that's enrolled through reduced drug costs as well as antibiotic-associated side effects. So to put it another way, though, for every dollar spent on the intervention, we save almost $4 for the healthcare system. And in absolute terms in Ontario, it's probably about $200,000 in savings, and that's just for the patients that are 65 and older, what we have data for. So these are very cost-saving interventions for antimicrobial stewardship in primary care. I wanted to show you this work as well. This is a systematic review and meta-analysis that we did that will be coming out shortly that tried to look at all the randomized controlled trials that have looked at antibiotic audit and feedback in primary care. There's a lot of heterogeneity in the way these are done, and we separated it by what outcome they looked at. So whether they looked at total antibiotic volume or specifically unnecessary antibiotics, prolonged duration antibiotics, or specifically selection of antibiotics, we showed that there were significant reductions in the meta-analyses across all of those outcomes from the trials. So there were about 56 studies that we could use that compared audit and feedback to no audit and feedback in a randomized fashion. And there was a 11% reduction in overall antibiotic use. There was a 23% reduction in unnecessary or inappropriate antibiotic initiation, 9% reduction in prolonged duration prescribing, and 16% in broad spectrum prescribing. And just to highlight that this is a very effective intervention. There's a lot of high quality data on audit and feedback for antibiotics in primary care that shows that this works. I would say like probably more than almost any other quality improvement initiative we do, and certainly in public health. Like I said, overall, an 11% decrease in antibiotic use, a lot of heterogeneity, and so the way that this is designed, how it's developed, how it's designed is actually really critically important for whether or not it will work. But our argument is that this should really be routine practice in primary care as part of antimicrobial stewardship and in general quality improvement. So I'm going to shift gears a little bit and just talk about other things to go along with it. I think as we talk about audit and feedback, I think we have a good evidence base that it works, it's scalable, it's impactful, but overall the reductions in antibiotic use are relatively small. It's a fairly passive intervention and relies obviously a lot on the physician just to make some small changes in their own practice. But there's more to sort of building community antimicrobial stewardship, and there are some evidence-based co-interventions that should be accompanying this as people and jurisdictions build these programs. So I want to highlight the Do Bugs Need Drugs program. So this is active out of BC for many decades now, as well as Alberta. These are their websites. And these have been, an active campaigns targeting both prescribers, but also patients about the importance of this, of antimicrobial stewardship, antibiotic overuse, antimicrobial resistance. And I think these things slowly over time do have an impact. This is federal data from pre-COVID, but just showing antibiotic use in the community across Canada. And I don't think it's necessarily coincidental or surprising that BC is consistently has the lowest amount of antibiotic use across the country, I think in part because they have this very sort of robust and engaged stewardship program. The public communication part is likely very important. In Ontario, we really don't do this at all at the moment. This is a systematic review that looked at 14 controlled studies that looked at public communication campaigns. So they're fairly heterogeneous, but there was 75 million people that have been involved in these studies in total, and they just summarize the data descriptively, but there's a range of 14 to 30% reduction in antibiotic use for respiratory tract infections from public communication campaigns. And I think this helps deals with the feedback we get from doctors, and I think it was evident in the word cloud as sort of this patient expectation component of antibiotics, which is certainly a significant challenge for a lot of walk-in clinic settings and primary care doctors. But the public communication part is important to directly address what the patients know and understand about this. So this is an important component that we should be incorporating into stewardship. I'll highlight a couple other things and studies. So there's some interest in biomarkers and point of care testing. So this is a Cochrane review on point of care biomarkers 12 out of these 13 trials specifically looked at CRP, or C-reactive protein, point of care tests, and they did show there was a significant reduction, 23% relative reduction in antibiotic use from using point of care tests for CRP. The studies that looked at it, there was no signals of harm, so difference in time to symptom recovery or mortality or signals that infections were being undertreated. I would say the cost effectiveness from the studies that have been done is uncertain. There's a bit of a mix in the studies, and I think it has a lot to do with how this is implemented. Again, back to the word cloud, the diagnostic uncertainty does not drive a lot of what we're seeing with antibiotic overuse. So if we do a lot of these tests for patient scenarios where it wouldn't have otherwise impacted it, it's very much not cost effective, especially when we just look at antibiotic use or antibiotic related problems. So I think the implementation for how these are used or how they supplement a stewardship program is really important, and sort of broad use probably is not the way to go. And I make a similar comment about pathogen testing. There's obviously a lot of interest in this as well. So this is a really nice systematic review and meta-analysis done out of a group in Quebec that looked specifically in the emergency room of antibiotic prescribing from doing rapid viral testing. And there was no significant difference in the meta-analysis on antibiotic use in this population from pathogen testing. And again, going back to that, is really not the diagnostic uncertainty is often one's not driving this over prescribing. So again, at the implementation, it's not that there's not a role for this. One good example that comes to mind is there's this nice study being started out of McMaster looking at children under 5 with chest x-ray confirmed pneumonia. We know that about 85% of those cases are viral and don't need antibiotics, and they are looking at an algorithm that includes rapid viral testing to see if they can actually reduce prescribing or prevent prescribing in the majority of those kids that actually don't need antibiotics. So there are scenarios, where it can be implemented and could be impactful, but again, broadly in the community is likely not the most effective stewardship intervention. I just want to highlight a couple other things, and I'll wrap up and take some questions. So we have this grant that we got through CIHR we call CAN-BUILD AMR, where we are trying to expand this work across the country. A lot of provinces and territories are either have started doing this or doing it in some way, and some of them not at all. So we are working together with a variety of federal partners, but also provincial, territorial partners to see if we can scale this up across Canada. Canada is really 13 separate countries and healthcare systems. But we're certainly making progress in moving this along and scaling this up, and it's exciting to see doing audit and feedback work more across Canada for antibiotics. And I want to highlight about the importance of partnerships in this work, that it has been really important to engage and partner with the family doctors and the College of Family Practice and the other sort of partners on the ground. It's really important that when we do these QI, audit and feedback initiatives, it really hopefully feels collaborative for most of the doctors. It's not, infectious disease telling them, how to practice or how to prescribe. We're basically repackaging their own data that exists in a way to help them improve their practice and try and, rebalance their priorities a little bit where there's a lot of competing priorities in primary care that often don't include antibiotic prescribing. Primary care is, overworked and underpaid and a very challenging specialty, and it's been really important to, again, work with these groups. No primary care doctor goes into an encounter or a day, not trying to do the absolute right thing or the best that they can. And so it's really important that when we do these interventions, provide this data, it's in that context and in that way that really just tries to support them in what is a challenging job. So with that, just summarize that AMR is a public health threat causing morbidity, mortality, and economic loss for Canadians. Most antibiotics are prescribed in primary care, and overuse is contributing to rising AMR. Antibiotic audit and feedback is effective and should be routine activity in primary care to improve antibiotic use and quality of care. Antimicrobial stewardship is about improving quality of care. It should be supportive, multifaceted, and requires diverse partnerships to make it impactful and effective. There are too many individual people for all the studies that I showed you, but just highlight the many institutions, funders, and partners for a variety of the work that I showed you in this. And with that, I'll stop and happy to take any questions.
Kevin. Questions? Mike's already coming to the mic.
Thanks. That was a great talk, Kevin. I have two unrelated questions. The first is my wife's a veterinarian, and they get taught to treat pneumonia for 28 days with antibiotics. Yeah. Has any of your work done stewardship for veterinarians?
We actually have a poster on that very question here. So Fiona's here somewhere, but
yeah.
There she is. So Fiona's doing a basically systematic review to pull all the data, veterinary evidence. Obviously, there's a lot less than humans, but there is evidence that you do not need longer durations for common infections. And that meta-analysis, I think, is only dogs and cats. It's not all animals. So if you have a hamster, I can't say for sure, you're sure. But likely, yes, that is too long for common infections.
Yeah, cool. And then the other question, I really like the CRP data. There's a group at McGill that recently had an editorial saying like CRP is totally useless, but I'm kind of in your camp and it is useful. So for certain clinical scenarios. So I was just hoping you could weigh in on that some more.
Yeah, I can't say I have a camp. I think it's, I think like all of these things, it's really important how it's used, right? So CRP, procalcitonin, like there is certainly a utility to these if they're used in the right way. So there's evidence that CRP will lower antibiotic use. So if you implement it and use it the right way, you will get that outcome. If you're doing a CRP on patients that are hospitalized every day of their hospitalization, there's no purpose in that, There is evidence that if you do procalcitonin daily in an ICU setting, especially in an ICU setting that uses too much antibiotics, you are going to significantly reduce antibiotic use. And actually it shows it probably reduces mortality as well by some mechanism. So it's not that these tests are not useful, it's that if they get overused and sort of blindly used, then they're not helpful. And so it's really about the indication and the goal of why you're doing the test and what it's leading to. So I really don't think every primary care doctor needs to walk in with a CRP point of care test for every patient encounter. But I do think there are scenarios where you could create an algorithm where you get to diagnostic uncertainty and it will predict with reasonable certainty, more than what you had before if the patient likely has a bacterial or viral infection, and then can help you with that decision making and also the explanation to the patient. So there is a role for it. There are also many negative studies for CRP, but in the meta-analysis, it overall is effective. So it really is, I think, how you do it.
Any other questions for Kevin? I had a great chat with Fiona last night at the poster session. Really, she was advising me on how to take care of my cats when I take them to the vet, which was great.
Yeah, it's very exciting. People often ask this, because obviously I'm a human doctor and a human, AMR researcher. But people always ask, well, what are we doing about veterinary work or the environment? And so it's very exciting when Fiona came to one of our colleagues, Nick Daneman, and asked to do a PhD related to antimicrobial resistance. It was very exciting for our team to expand in that way, because historically is not really part of what we've been able to do.
Oh, I think we have an online question, too.
We do have an online question. Yeah. The question is, in Canada, what are the impacts of factory farming and use of antibiotic use?
Wow.
That's pretty broad. Yeah. That's a big question, Kevin. What do you have?
Yeah, I think there's probably been some, I've missed most of this conference, but, the One Health aspect of AMR, I think can't be overstated. So there's all this stuff is connected, right, in terms of the overuse of antibiotics in animals, the overuse in agriculture, the overuse in humans. They impact each other in a variety of ways. I do think, as terms of like a hierarchy of importance, antibiotic overuse in humans is probably the most important thing for human AMR, right? There is obviously, crossing over, but the human stuff I think is the most important. For sure, antibiotic overuse in these other settings is impacting multiple areas in the landscape of AMR, and it's really important that we do work in this sort of One Health space across fields. Like, I can't do environmental AMR work and collect sewer data and do animal-related research, but we need that as part of our approach to AMR, and I think it's really important that we work together with these different groups for that. So I don't know, I danced around the question because I probably don't really know the answer, but that was my answer.
Oh, that's great. I think we have one more online question, and then maybe we'll wrap up after that question.
Thank you. What should LNHs, or LHNs rather, or health systems in Ontario do to implement stewardship in patient interactions?
Yeah, it's a great question. I think you mean like the regional, like we don't have LHINs anymore. They've abolished that, and Ontario healthcare system is under one thing called Ontario Health now. And so we've certainly worked with Ontario Health regarding they do Audit and Feedback, which I wasn't able to talk about in the short talk, but you can electronically also receive antibiotic audit and feedback for primary care doctors in Ontario through Ontario Health. Another really interesting part is what the public health units, what can like local public health do towards stewardship, which they've historically not been so involved in. And like Brad Langford has been leading some work in that I think there's a lot more engagement we can get from public health units and the public health system in general in terms of education to the public, education to prescribers, and really, collection of data. So there's probably a lot of aspects that the local public health units can get more engaged in. And I think it's sort of incumbent on us probably in the EMR community to engage these groups more for that work.
Amazing. Thank you so much, Kevin.
Thank you.